spotlighting Hawaii's leaders.
We want to bring in Governor David E.
Good morning, Mr. Mayor.
Lieutenant Governor, good morning. Thanks so much for joining us. Mayor Derek Kawakami.
Thank you so much, Senator, for being here.
Spotlighting the issues.
Where is the virus right now in our community?
How much is this overall going to cost the state?
How are you responding to the community's concerns? Talk about the level of citations that you guys are writing.
Spotlight Hawaii with Yanji Denise and Ryan Kalei Suji on the digital platforms of the Honolulu Star-Advertiser.
This episode of Spotlight Hawaii is brought to you by Long's Drugs.
Well, aloha, good morning. Thanks for joining us here on this Monday morning. I'm Ryan Kalei Suji, joined by Yanji Denise, and this is Spotlight Hawaii on the digital platforms of the Honolulu Star-Advertiser. This morning, to start off the week, we are focusing our conversation on COVID-19. This, as a new variant, continues to make its way through the country, causing concern by those in our medical community.
That's right. Hospitalizations are up nationwide. Right now, there are over 31,000 people in the hospital across the country. So what does that mean for us here in Hawaii as more and more people seem to be testing positive for the virus? Joining us live now is Dr. Todd Allen, Chief Quality Officer of the Queen's Health System. Doctor, good morning.
Good morning. Thanks for having me on.
Thank you for being here. Let's talk about first hospitalizations, because we know that our leaders really use that as an indicator for how to implement COVID mitigation measures. What are you seeing in the hospitals here in Hawaii at this time?
Yeah, hospitalizations from COVID continue to be up. They're down from their heights of this particular surge, what we're calling the BA2 surge. They're down a little bit. We have about 58 hospitalizations across our system. Today at its peak, it was about 85 to 90 just a couple of weeks ago. That's still less than the 140 that we saw as a record in the first wave of Omicron and back in Delta.
Let's talk about this new variant, the BA5, and just the difference that we're seeing with this variant compared to other forms of the Omicron variant that we know really hit Hawaii hard just a little bit ago.
Yeah, this is a real remarkable variant, and we're still learning about it. It's relatively new, but it is the most different from the original strain by far of any. And it's even further different from Omicron 1 than Omicron was from that original Wuhan strain. And it's really a bunch more infective than what we've seen before. And consequently, because it's different and because it's more infective, you know, it's kind of getting us all again, even weeks or just short months after maybe we had Omicron 2. Major differences in the spike protein, major differences in the rest of its genetic sequence. So really easy to catch again, and almost like a brand new virus. We're going to have to be careful with this version of the virus. We're going to have to think a little differently about how to mitigate it and prevent infections. And we're going to have to act differently, I think, as a community and as a nation to help keep the infections down. Now, that said, you know, with Omicron and with COVID now, it's less about preventing infections because it's so infective, and it's more about keeping people out of the hospital, and especially about keeping people from suffering and dying.
Well, let's talk about, you mentioned that this is basically like a whole new virus. So what about the protections that we do have, when we talk about immunizations, boosters, and then, of course, people having so-called natural immunity from prior infection? How does that all stack up against this new variant?
Yeah, great question. And I think it's, led to a confusion in a lot of folks. And they say, well, if I'm going to get it, if I got it, what good was the vaccination? Well, first of all, the vaccines designed against that original strain still remain pretty effective against hospitalizations and death. And that's important. That's really important. Now, I do think we're going to see new vaccine versions come out that are more customized to Omicron, and that will be a big step forward. And think of that a lot like the seasonal flu vaccines that we have every year, right? The flu is a little different as it travels around the globe, and scientists and vaccine manufacturers try to make their best assessment of what version of the flu we'll see in any particular place, and then they customize on a yearly basis that vaccine. I think we'll get to that place really with COVID. What we do know is that previous infections and the vaccine, and especially the boosters, all contribute to make your body better able to mount an immune response, to make antibodies against whatever version of the virus comes and to make them quicker. And that's the thing, right? Is you can get infected, you can get this big viral load, but your antibodies ramp up pretty quickly too. And it's in the production of those antibodies and the circulation of those antibodies that they attack and destroy the virus. And that's what is making, in part, Omicron, even though lots of infections, leading to less hospitalizations and especially, less ICU hospitalizations. So every bit matters. Natural immunity, vaccine-derived immunity, it all matters. It all helps your body do the thing it was designed to do. The challenge with catching COVID, and sometimes I hear people say, oh, I'll just go catch it then and I'll get naturally immune, except for the complications of COVID. They're really serious, and we're still beginning to understand that. And long COVID, increasingly prevalent, increasingly common, you do not want it. I see patients, I talk to patients with long COVID, even mild versions, where the symptom might just be fatigue. You don't want it. So vaccines, I think, are still the best and the safest way by far to teach our body to recognize the virus so that if it does get us, we're able to quickly mount that immune response and have less severe disease.
What would you say about those who are waiting to get their boosters? Maybe they're saying that they want to get a booster that will include some of the protection against some of these new variants. At what point in time might it be a good idea to go out and get this booster? Would you recommend that people wait, or is this something that it should be done immediately?
Yeah, I would do it now. I totally get that question. It's gone through my mind dozens and dozens of times. It's still far enough out, and it's still uncertain enough, and BA.5 is among us. 4 and 5, I think, accounted for 20% of the viruses last week in Hawaii. I'd be surprised if it wasn't double that this week or by the next measure. So I would do it. When we figure out what the next version of the vaccines look like, terrific, and we'll have good recommendations on that. But there's enough uncertainty around it now that I would go ahead and get that booster. It will be helpful.
We like to bring in audience questions, and George White has one. He says, what differences in approach have improved our response or management after 3 serious surges of uncontrolled transmission in 9 months and now facing BA.5 and whatever's next? You did mention that we might have to change and adjust our behavior and how we approach COVID with this new variant. What specifically should we be doing differently?
Yeah, a couple of things, I think, and thanks for the question. And it really has been remarkable to look back at those surges. As a country, I think collectively, we, quote, decided, that COVID was over, and that there didn't have to be restrictions like we had lived through before. I think a part of that was wise. There are economic consequences and social consequences and psychological consequences to the lockdowns that were necessitated by COVID that we've got to start to take into account. What we can still do is be more collective with each other. And by that, I mean, let's wear masks again when we're outside, when we're indoors, and in crowded rooms. Let's stay home if we feel sick, and let's monitor our symptoms. Let's do home testing as the kits are now available. Different behaviors that can help us have a better sense of if COVID is in us, if we're being affected by COVID, and to protect ourselves from COVID when we're out, and to protect others from COVID when we're out with our behaviors.
One of the things that, as you mentioned, many in the community are getting COVID and they're taking home tests. And for those that get that positive test, many wonder what they should do next. I'm on a text string with some friends, and there seems to be, some those who get infected. There seems to be just a variety of thoughts and principles about what you're supposed to do, how long you're supposed to stay, in quarantine. If you can sort of break that down for anyone out there who may get infected, what is the recommendation at this point in time about how long they should remain in quarantine and some of the other things that come along with those who may find themselves in this situation?
Yeah, great question. The CDC has kind of muddied the waters here, and it's a little discouraging, being a physician and an administrator here at Queens. So first of all, let's acknowledge that we're really lucky now to have home tests. They're not perfect, those antigen tests, they're not perfect, but what a terrific tool to have in our armamentarium versus the PCR test that we had to line up for, the big deep swab in the nose, and it takes 3 or 4 days sometimes, at least in the early days, to get this test. So we're lucky to have them. We should all have them in our house. If I had symptoms today, first thing I'd do is I'd say, well, COVID's by far the biggest virus in circulation right now. It's not allergies. It's probably COVID if I feel sick. I'm going to isolate. I'm going to take myself out of circulation. I'm not going to put other people at risk. Now, that COVID test, that home antigen test, which I hope, again, we all have, most accurate probably if you have symptoms and probably about 2 days into it. Early on, I've seen lots of reports of what we call a false negative. So I actually have COVID, but because the virus isn't circulating heavily in my body, it's early in that infection, I take the test and it's negative. I think, okay, I'm fine. I can go back out there. It's not. If you have symptoms, give yourself at least 2 to 3 days to run that test again. And I've done, I'd recommend it to family and friends, 2 tests about, every 36 hours apart, 2 or 3 tests about every 36 hours apart, really to have a sense. If that thing ends up positive, I think you're still stuck in isolation, should be stuck in isolation for 10 days. Now, the CDC moved it to 5 if you are asymptomatic. The problem is you're still shedding virus most of the time at 5 days. Not all the time, but most of the time. In fact, the symptom that you can shed from as low as 3 to as high as probably 9 to 10 days. So what the CDC actually said, and we missed the second part of this, is isolate for 5 days. The second part of it was wear a mask for the next 5 days if you go out. And we didn't hear that part. We just heard, hey, I'm free at 5 days, and here we go. So I would still stay in. And in Queens, our habit is that it's a minimum of 7 days. And then we very closely call those caregivers, nurses, respiratory therapists, pharmacists, physicians who are positive, and we say, okay, it's on day 7, how are you feeling? Do you have any symptoms at all? And if no symptoms, then we'll do some testing again. And if that's negative, bring them back to work. So minimum of 5 as the CDC recommends, but only stop it if you're asymptomatic. And even if you're asymptomatic, wear that mask for the next 5 days. I prefer longer. I prefer 7 to 10.
Let's talk about folks who do get that positive home test and may be immunocompromised, maybe elderly, may have another condition, or may just feel really poorly. What are some of the options in terms of, we've heard about monoclonal antibodies and Paxlavid. What are some of the treatments available, and how soon do we need to get those? How do we actually get those treatments if we think we might need them?
Yeah. Well, look, 5 and 10 years from now, when we look back on this episode, I think we're going to be amazed at how quickly science and medicine and government and so many people made progress on a brand new virus that we'd never seen before, without any diagnostics, without any therapeutics at all. So there's some good news to be shared there, right? Vaccines we've mentioned. For treatments, we've got some pretty good tools. I think we'll get better tools as we go along. The outpatient treatment you're referring to, if I'm not sick enough to be in the hospital, it's called Paxlavid. It's a combination of 2 antiviral drugs brought together that you take typically for 5 days. So if I was older, it's actually approved for use for those above 12 years of age. If I were feeling symptoms and I had a cough and I had mild to moderate infection, I'd probably try to get started on Paxlavid, like you mentioned. Now, to be most effective, it ought to be started within 48 hours of symptoms is best. Within 4 days of symptoms is okay. And yet, again, you take it for 5 days. Now, the antibodies that can be taken, there are 2 types. There's monoclonal antibodies that we can treat you with, essentially antibodies from people who have had COVID. And we infuse them very carefully under close observation. And just like your own natural antibodies, they'll glom on to the virus and fight that infection. So we can use that. If you're at high risk and you need protection, there's a medication called Evusheld. It's a collection of antibodies that are long lasting. And you can have that given as a preventative measure if you're at high risk for complications of COVID, and can offer some protection as well. For the inpatient, if you're sick enough to get in the hospital, there's some other medications that are used there. Remdesivir, an antiviral you might remember, dexamethasone, a steroid that helps tamp down the inflammatory response, that heavy immune response you sometimes get with COVID, and some inpatient antibody medications as well. But Paxlavid is the mainstay of our outpatient treatment now. We're getting better at distributing it. It's been hard to come by. recognize that shortcoming in our response. But there are a few drug-drug interactions. People with kidney disease and liver disease should be careful. But this can be given, I think, really quite safely with the supervision of your physician or pharmacist.
Given all those medications that you listed off, including those that you administer to those who unfortunately make their way to the hospital, we are also seeing still a number of people who are passing away due to complications with COVID-19. I'm wondering if you can shed some light about some of those individuals. Is there any trends that you're seeing with medications that's not working for those individuals? Are these all individuals that maybe were unvaccinated or suffered from another medical condition that that COVID kind of put them over the edge? What are we learning about where we're at right now with the deaths that we continue to see related to COVID-19?
Yeah, the story of the deaths from COVID is just so tragic. Recall back in the summer and the early fall, 100,000 Americans each week were dying of COVID. It's now down to 10,000, and we say down to, and we take that as some measure of comfort. 10,000 Americans still dying a week of COVID. We saw at the height of Delta, about 10 citizens of Hawaii die in our hospitals every week. 10. We're now down to 3. Only a third of that. 3 people a week still dying of COVID, here. And so it's still really among us. The people who are in the hospital and are sick now are mostly vaccinated. They're the elderly, our kapuna, with some chronic illness. Think about heart failure, think about kidney disease, think about diabetes, lung disease. So our elderly, who are largely vaccinated, over about 60% of those in our hospital are vaccinated. And it's because, again, Omicron is just different. Immunity wanes. It's different enough where people get infected. And again, when you're a little older or have chronic disease, it can sometimes be quite severe. It's not that they've tried and failed any particular therapies or they have anything else really as part of the story. It's just that Omicron is still COVID. COVID is still quite serious, and even if you have the vaccination, it can be very severe. Gratefully, though, again, nowhere near the numbers that we saw at the beginning of the pandemic with Delta and beyond.
One of the things that some good news that happened in the last few weeks is that keiki under 5 can now get the vaccination. What are you seeing with the uptake of families in terms of people actually going in and getting their young children vaccinated? And what do you say to parents who may say, oh, I just want to wait a little longer. I want to see what's going to happen to the classmates, or, oh, it's not that serious in kids and we don't really need to vaccinate. What do you say to those folks?
Yeah, I think the same advice. I think parents are really considering their options thoughtfully and carefully. They're making the best decisions that they can with the facts that they have in front of them. That's the way healthcare, should be, is that providers and systems sit down with patients and families and carefully discuss the risks, the benefits, and the options, and then make the best decision. Now, I think the best decision here is for the vaccination. And as a system, we'll say that. As an individual physician, I'll say that. There has not been the rush amongst children less than 5 that I would hope for the vaccine. I remember when I received my first vaccine, I remember in those first days that we offered the vaccination clinic first on Blaisdell, first here on campus, and then at Blaisdell, literally, actually tears of joy from people, and I had my own tears. I'd hoped for a little bit of a more urgent response from parents for their children who are less than 5. We're getting a steady stream each day. We're delivering it really at 3 main clinics, branching out to 5 and then to more pediatric clinics and other clinics. No complications, no problems thus far that I'm aware of. And I try to keep pretty well attuned to that. But I'd encourage folks to sit with their physician, their pediatrician, and talk carefully about the options, the risks, the benefits. Again, it does look like it's a different disease, a milder disease in children, except when it isn't. And we have yet to understand the long-term complications of COVID, even in our pediatric population. That's what we're trying to prevent at least in part, with the vaccination program for now, really all Americans.
Want to bring in another question and asking, are the symptoms of BA4 or 5 different from other variants? Are we seeing any different responses from this as we see these different variants come out due to COVID-19? Have we seen different symptoms that people are suffering through as a result of that?
A little bit, yeah, very interesting, right? So I think when you look again back on the Delta wave, that was devastating. It was unbelievable suffering, unbelievable death. The virus for Delta and those early variants had a particular affinity for the respiratory tract and the lower respiratory tract, the lungs. Now, COVID, BA4 and 5 still do, but a more of an affinity for upper airway symptoms. So the runny nose, the light cough, the sore throat, the scratchy throat, more of affinity for nose and throat issues. So we have seen a little bit of shift from lower lung, which was what caused the death in the Delta surge, to now the upper respiratory symptoms. It's still associated with a cough, but a little less prominent. And that's the biggest symptom change that I've seen.
I want to circle back to kind of where we started with the hospitalizations and also the hospital's ability, the Queen's Health System and others in our state, to handle the influx of patients. You know, we focused on the patient population coming in, but the other side of the coin is having enough workers. And we know with so many infections, surely there are exposures in your system and people who need to stay out. So given how prevalent this variant is at the moment, are you able to staff to the needs that you have? Do you have to bring in traveling nurses? We heard so much talk of the federal help early on with these other surges. How are you doing from a staffing perspective, given all the exposures to COVID?
Yeah, great question. It's really been remarkable. Short answer is no, we're still behind and we're still struggling. Not as much as we were in June, but still struggling. The story of Omicron, has been just as you described. If Delta was about, death and just the real difficulties associated with how much suffering there was, this one is about workforce. Because our workforce was getting COVID, especially once the restrictions came down in the community, mask wearing and allowance of gatherings. Our workforce was getting COVID just like everybody else. We then are doubly obligated to be careful and keep those folks out of work. We can't afford to give a single patient who has sought our care COVID while they're in the hospital. As it happened, it has. And we take every one of those things very seriously. So we keep the workers out. And so consequently, we were down at any given time in June about 300 to 400 workers just out of the workforce. You can't bring in enough travelers to close that gap, but we did. And we still have travelers with us today. They're slowly coming back. The tide is slowly turning, where we have more coming back to work than going out of work because of COVID, an exposure or an infection each day. But it has been a struggle. One of the most challenging human resource problems that I've seen in healthcare ever in my career, and by a long ways. So we've still got some work to do. I know this is true across the state. I would get on calls with other leaders from across the state, and every hospital was affected by workforce shortages. It's something as Hawaiians that we're going to have to work at over the long term if we transition, and we have to transition to COVID sort of being among us in some form or another, at least for the next 5 years. And as we continue to learn to adapt it, the workforce strategies are something we're going to have to figure out as well.
Beyond just the physical impacts of COVID-19, as you just spoke about, to the impacts of your workforce, I'm wondering if you can share a little bit just about the emotional and mental, well-being of your employees. I mean, this has been a long 2 to 3 year process for many of them, long hours, of course, the early going times of COVID-19 and seeing all that our healthcare workers were going through. I'm wondering how just the staff overall is holding up and just being able to retain some of these workers to continue to push through, especially when we continue to see these new variants coming up and knowing that this work is not yet over.
Yeah, thanks for asking. It's disheartening. It really is. On one hand, I certainly recognize how great nurses, physicians, shared clinical service workers, housekeepers, nutrition support, pharmacists, therapists have been during the entire two years and change now. When they went into those professions, they went in to serve, and they've honored those service obligations. On the other hand, they are tired, they're worn out, and some days it's hard to go on as we speak together. As we saw Omicron 1 sort of settle down, and then Omicron 2 pop back so quickly, and now Omicron 4 and 5 kind of get melded into the end of 2. When you're on calls, when you speak with your colleagues, you can hear the exhaustion, you can hear the fatigue, and you can hear the discouragement. Like, I just need a break. We need a break. We need to go 2 months without COVID just ringing in our ears incessantly. And that the fates won't hand it to us is really disheartening. So we think about our caregivers, our colleagues every day. We try to support each other. The public's been terrific. And we want to continue, to do the things that are necessary to continue to have the support of the public, civic officials, and our families, so that we can continue to slog through. Relief has to come at some point. We have seen at Queens, like in other places, people just say, I can't do it anymore, and leave. I think there'll be more of that to come. Many are still working out of their ethical obligation and ethical commitments they made to serve patients as they again entered the healing professions years ago.
I think that the sentiments that you're talking about, a lot of people feel that not necessarily in that severe way, but just across the community, you feel this fatigue and this declaration that we're done with COVID. COVID is POW, but COVID clearly from our conversation today is not over. In just the last few minutes, just as the final question as we wrap up this morning, what's your message to the community as we face this new variant? What are you asking folks to do? And just your message about this next phase.
Yeah, I'd say 2 things. Number one, recognize that the hospitals are functioning, they're functioning well. But when you come here, there's going to be some different rules because of what we're trying to do. It's not the community, it's a hospital. It's a place where people who are sick and vulnerable come to get cared for. And so, we're still asking about your vaccination status. We're still having our guests wear a mask. We're still limiting visitor hours and the number of visitors in total. It has to be that way still. So please understand and have some forbearance on that. Work with us, talk with us if you have concerns. We want to hear them, but we're going to have to keep things tight for a little while to protect, again, the vulnerable who are within our walls. Number 2, as COVID and BA5 and 4 come through the community, do those things we talked about earlier. If you feel symptoms, take yourself out of circulation and isolate. If you're exposed to someone who has COVID, take yourself out of circulation and isolate. Please wash your hand. Please wear a mask as much as you can, and test. Do that home testing so you can have a better sense of whether you're positive or negative, and then take the appropriate actions. We have got to be good stewards of each other. We miss that time and time again in COVID thus far. It'll be, again, one of the great stories of failure, frankly, as a society when we look back on it. But be good stewards of each other, especially as BA5 and BA4 get going in this community, and they will. We're going to see our infections go up, just as you described, in the rest of the nation.
Okay, Dr. Todd Allen from the Queens Medical Center, thank you so much for spending the morning with us and starting off your week by providing that information and update about where we're at with COVID-19 in our community. We appreciate the conversation and all the insights, and look forward to maybe having another discussion down the line with some much better, brighter news to come in the future. But thank you so much.
Thank you. There is good news to be found out there. We just have to be careful still. And thank you for the time. I enjoyed it.
Aloha. Thank you so much. Well, Ryan, he was fantastic. If you missed any part of this conversation, remember when the live broadcast is over, you can go back and rewatch it. Also available later this afternoon, anytime as a podcast, and later on the rebroadcast at Channel 50. But so much information throughout our conversation about what to do if you test positive. He had some really good points about the fact that the CDC is recommending 5 days of isolation after you show symptoms, but that there is a page 2 to that. And the page 2 is that if you still feel sick, stay home. If you don't, you still need to wear a mask for an additional 5 days after that. He said that's something that's really gotten lost in the messaging. He talked a lot about the treatments that are available, and there are more and more of those that are available, and also encouraging people that if you're eligible to get a booster now.
Yeah, you heard that recommendation from him saying not necessarily to wait to see when a new booster will include some of the immunity against these new variants we're seeing, but rather that a booster should be taken sooner rather than later, than waiting for that. We also just heard the breakdown of some of the differences that they're seeing with this new BA.5 variant, and it's spread through our community as we're seeing across the country and across the globe, with this becoming the more dominant strain. And it's difference between what we saw with Delta in the that it is more affecting the upper respiratory area. And so we'll see a little more, as he said, runny noses, cough, sore throat, maybe than what we saw. Still a cough, but maybe not as much of a deeper cough. He also reported just the numbers and what they're seeing in the hospitalizations overall. People continuing to die. He's saying about 3 deaths a week continue to be what we're seeing here in the islands. But overall hospital counts continue to remain manageable at this point in time.
Yeah, and very interesting also when he said that what people assume is natural immunity from having caught COVID doesn't necessarily hold up against this variant. And even vaccination, it can prevent hospitalizations and severe illness and even death. And so that is very important. But he says that this is basically a new virus under this new variant, and something that we really need to be careful for. He's highly recommending masking up in an indoor situation, even if it's not mandatory, just as a precaution for yourself. Also recommending that parents get their young children vaccinated. He said he's been disappointed with the uptake of the vaccine for those under 5, recommending that parents talk to their pediatrician and make that decision for themselves, but they're not seeing the rush that they had hoped for in those young kids. And he also referenced long COVID, which we're going to have a deeper discussion on Friday about. We've invited a doctor here, also part of the Queen's system, who has done a lot of research into long COVID and helps to run their long COVID clinic. We're going to be taking a deep dive into what long COVID really is and what you can do to prevent it. So looking forward to that conversation on Friday. On Wednesday, though, Ryan, we delve back into the world of politics.
Yeah, we're going to be catching up with Governor David Ige, getting his thoughts on where we're at as a community, of course, when it comes to COVID-19, but also what we're seeing with the overall budget. The legislature, of course, passed a number of items in the budget that the governor had to adjust when signing these measures into law. We also saw a number of bills that the governor plans to veto, and getting an update about a number of different issues that our state is facing right now with the economy and with gas prices. And just there are a lot of conversations to be had when it comes to our interview and our time with the governor. So we hope you'll join us right back here on Wednesday at 10:30 for Governor David Ige and another episode of Spotlight Hawaii. We'll see you then. Aloha.
Aloha.
This episode of Spotlight Hawaii is brought to you by Long's Drugs.